Good afternoon, ladies and gentlemen. My name is Dr. Ryan Maves. I'm the chairman of the CHEST COVID-19 Task Force, and it is my privilege today to be the moderator for this session entitled COVID-19. How did 1918 prepare us for today, and how will 2020 to 2021 prepare us for tomorrow? We're very fortunate today to have two expert panelists with us today, Professor Dale Smith, professor of military medicine and history from the Uniformed Services University in Bethesda, Maryland, and Dr. James Lawler, associate professor of medicine at the University of Nebraska Medical Center in Omaha. Today, we're going to start with a discussion by Dr. Smith about the history of prior pandemics, most notably but not exclusively the 1918 pandemic. We'll then transition over to Dr. Lawler, who will offer some thoughts and perspectives on our contemporary pandemic and what this means for future pandemics. Then we'll lead into more of an open discussion where we'll have a chance to discuss your questions for Dr. Smith and Dr. Lawler, as well as any questions that may arise spontaneously in the course of our discussion. So thank you all once again for being here today, and I'm going to turn it over to Professor Smith.
Thank you very much. I think everybody has heard that this is the pandemic of the century, and we go back to the last pandemic a century ago in 1918 and 1919, often called the Spanish flu. It wasn't Spanish. It was flu. We now have sequencing from patients to prove it's an H1N1 flu. At the time, they called it flu. Influenza was not a new problem. There had been a European influenza epidemic in 1889-90. But it hadn't hit America very hard because America was largely a rural agricultural country, beginning our industrialization and city growth. But Brooklyn and New York were still different cities then. And they kind of grew together by 1918, and the borough system came about. And we began to get cities on the West Coast. Hollywood was getting started. The challenge of comparing those experiences is there are huge differences in science and society and what was known. It is important to recognize that the best minds suspected the flu was viral. Virus is another word for germ, depends on whether you use Greek or Latin, but it's the source of something that you might think of it in English as seed. A virus in 1918 was an etiologic agent that would pass through an unglazed porcelain filter. Nobody had ever seen one. Electron microscopy and crystallization are 20 years in the future. What you do find is a variety of what we would call secondary infectious agents in people. Haemophilus influenzae was identified as one cause of the flu for this reason. And other viral and bacterial agents were causes of respiratory disease at various times. I mean, the pneumococcus had been identified, meningococcal pneumonia had been identified. People understood that with measles, you sometimes got a pneumonia associated with it. But this was different. This ran through army camps. Remember, Europe had been at war since 1914, but we entered the war in 1917, and it took a little while to spin up. The first clear case of flu in 1918 that anybody can find is in Kansas. Camp Funston. The Army identified it. The Army Medical Department said, this appears to be infectious. The Army said, we are mobilizing to send people to Europe. People need to go to training camps. It's just the grip. And normally flu is not particularly a problem. It would take a while to recognize that this flu did not have a U-shaped mortality curve. Normally, respiratory disease has a U-shaped curve. The young and the old die. Everybody in the middle gets along pretty well. By late 1918, it was pretty clear that this flu had a W-shaped mortality curve. Hard hit were people in their 20s and 30s. Not as bad as the two extremes, but still this was different. But because they didn't know that, they kept mobilizing. Flu moves through Boston and Philadelphia on troop transports to Europe. There's a war going on, so nobody says anything. It hits France pretty hard. It's hitting Britain pretty hard. But when King Alfonso of Spain gets sick with the flu, Spain being neutral, they, of course, put it in the newspapers. They aren't censoring the news. And so it becomes the Spanish flu. It will move on and stop the German 1918 offensive. It probably helped in the war. It certainly made a lot of troops sick and killed a lot. Moved on around the world. Didn't hit China as hard, and this leads to some speculation that it had an Oriental origin. There had been some not as bad flu in 1917 in China, because nobody could type flu, nobody knows. But certainly the pandemic swept around the world, depending on exactly how you count, 3 or 4 times. Came back to San Francisco in 1919 and came back across the country. We responded locally. All public health was local in the early part of the 20th century. And so different cities, states had different effects. The public health officer for New York didn't think it was a particularly bad or communicable problem early on and did not want to interfere with business. Whereas by the time it swept back around to St. Louis, they locked down tight and closed the schools, closed the theaters, told everybody to stay home. Placarding houses was the chief public health measure for all diseases at that point. A placard for diphtheria, a placard for measles, whooping cough. New problem of polio was coming along and came every summer. So the public health people were used to quarantining people. Didn't have many immunizations yet, but we had a few. They were largely bacterial. And when people thought this was a bacterial disease, they set out to make a bacterial vaccine. Of course, it didn't do much good. Finally figured out it was a virus. You could make an attenuated viral vaccine. Pasteur had done it by accident with rabies. But doing it intentionally was a little harder. And so serial passage of flu didn't give us a very effective vaccine until we got better cultivation methods in the 1920s. Goodpasture at Vanderbilt would develop the egg method of growing viruses, which until very recently was still the method of growing viruses for vaccines. The challenge was because of this local response. Nobody had really good data anywhere in the world. There is no World Health Organization. PAHO is being negotiated. So the exchange of information was very difficult. And the exchange of science was difficult because of the war. You can't send somebody to a scientific meeting in Germany if there's a war going on. So you had communication problems, but we did manage to move the flu regularly around the world because we were moving people during the war. In the United States, we probably killed 200,000 people, influenza and pneumonia in those 2 years. Now you think, well, that's not so bad, but the United States was about 30% as densely populated as it is today. And so by the time this is over, they will probably be comparable. That's a little scary because the world was not as populated either, and it kills somewhere north of 50 million people around the world. Incidents in the United States that we can document. Now remember, all of this is very idiosyncratic, but data out of, for example, New Jersey showed about 1 in 250 citizens of New Jersey got the flu in one of those 2 years. The current rates for COVID are about twice that, a little more. So how it compares depends on which counting you use. And so it's a little difficult. It would not go away. Flu would come back episodically every winter, but it wasn't the bad flu. But there were plenty of bad diseases. Whooping cough didn't have a good vaccine. Measles didn't have a good vaccine. There were anti-vaccination movements against smallpox and typhoid. BCG was not yet available for tuberculosis, and so you had a lot of open schooling. And polio was rising. It hit the President of the United States. By the 1950s, the understanding of virology was enough that you could make vaccines. And so Salk and Sabin, Morris Hilleman. And when the Asian flu came in 57, Hilleman recognized it from samples coming out of soldiers in Japan. And now we could make a vaccine. It wasn't 100% effective, but he got 7 companies to begin to make it. And so we had some vaccine. In 68, the military was coming back from Vietnam with the Hong Kong flu, and we were sending people to their home of record at the end of their tour. So discharging draftees helped disseminate flu, and America was much harder hit than Europe by that flu pandemic. So the social issues around epidemic spread, diagnosis, and prevention remained in further flus. It is important to recognize that by the 70s, we have the modern system of vaccines. The childhood diseases are going away, and we have a new generation. The millennials, the baby boomers are closing out about 65 for births. And so only about 25 to 30% of our population in 2020 has any memory of standing in line for immunizations for polio, for being locked up in the summer, by traveling and coming to a billboard at the county's line saying polio outbreak, do not stop in this county. Those kinds of things are in my memory, but very few of our citizens had those kind of memories. And our emphasis in public health had been on chronic diseases, obesity, other kinds of problems for a generation. So we were, in some ways, looking at a different set of problems in public health than we were in the first half of the 20th century and the childhood of the baby boomers. And I think those social distinctions are phenomenally important in our handling, and it may tell us something about both our experience this time and what we need to think about going forward. And with that, I will turn it back to you to pass into the future.
Thank you so much, Dr. Smith. And I'm going to take the liberty of mentioning to our audience that Dr. Smith is getting ready to retire from the Uniformed Services University after, I believe it's over 40 years of institution, sir. And he's been an educator for a generation and change of military physicians. And I know that the use is going to be very, very sad to see him go, but also very appreciative for all the time that he's spent in service to both the university and to the country. So thank you again, sir. So it is my privilege to turn it over to Dr. James Lawler, who is Associate Professor of Medicine at the University of Nebraska, as well as the Director of the Global Center for Health Security at the university. Dr. Lawler, all yours.
Thank you, Ryan. And Dr. Smith, thank you for that great look into the 1918 pandemic and the cascade of effects from that pandemic that I think still touched on our experience in the 2020 COVID-19 pandemic and continue to. They certainly shaped much of the pandemic preparedness work that went on in the mid 2000s and in response to 2009 H1N1. Unfortunately, many of those lessons were forgotten or ignored and would have come in quite handy in the last year and a half. Ryan's charge to me was to take a look at the lessons learned from our current experience with COVID-19, and then perhaps to discuss a little bit what those lessons portend for the future and the next pandemic, which I think we all agree will eventually come, and probably, unfortunately, we will not wait another 100 years for a century-scale pandemic, given the accelerating rate of emerging infectious diseases and the vulnerability of a globally interconnected community, which I think has been highlighted quite well over the last 18 months. So I think there's a few important lessons maybe that I would take away from the experience that we've had since January of 2020, and that have significance for future events. First is the fact that these pandemics are not static events. And as Dr. Smith pointed out, while we talk about the 1918 pandemic and Spanish influenza as a phenomenon of 1918, I think Dr. Smith very accurately described the fact that the pandemic continued into 1919, and even 1920 and 1921 were all years of unusually high influenza activity compared to normal seasonal influenza, as epidemics cycled through portions of the population that were not yet infected. And the lesson there is that these highly transmissible respiratory viruses eventually get around to everyone. And while we talk about herd immunity thresholds, and when we get to a certain percentage of the population being infected, the epidemic naturally dies out. That doesn't mean it dies out forever. It comes back. And the natural endpoint for circulation of these viruses is when the entire population is no longer susceptible. And when that's not achievable, then you get continued background transmission of these viruses, which is going to be eventually what happens with COVID-19. It will never go away. It will be with us probably for at least the foreseeable future, and most likely the rest of our lifetimes. And so that lesson there is this idea that this is not a single event in time, nor is it something that has a direct and linear trajectory. As we've seen in the last several months, we've had really pandemics within pandemics now, with new variant strains of the virus, including the Delta strain now out of India, which has rapidly and dramatically taken over as the predominant virus circulating in the United Kingdom, is probably also the dominant virus circulating in much of sub-Saharan Africa, much of South and Southeast Asia, and now appears to be poised to outcompete the P1 virus that came out of Brazil as the most predominant form of COVID-19 or SARS-CoV-2 in the United States. And these viruses, these new variant viruses, are behaving significantly differently than the original virus that emerged out of Wuhan. So in particular, they are clearly much more transmissible. They clearly have the ability to escape immunity, at least immunity imparted by previous infection with the strains of the virus closer to the original Wuhan virus. And they also appear to reflect more the phenomenon of 1918, where younger people are more susceptible to severe disease, as opposed to the original virus, which had, I guess if you're going to use letters for shapes, almost a reverse L, where really the majority of severe cases and deaths only occurred in seniors, which is one reason why many low and middle income countries were spared, because of their different demographics, whereas the new virus clearly has much more predilection to cause severe disease in those populations. So we've seen dramatic changes in the pandemic itself over the last 18 months. And in part have been able to witness those with much more granularity because of the advent of new technologies such as PCR and genomic sequencing, which has enabled us to really follow the evolution of the virus as it's emerged. The second lesson I think that I would take away, which is one of the good news stories of the pandemic, there aren't many, but this is one, which is the advent of novel technologies in our fight against these emerging disease threats. First and foremost, I think, are the vaccines, both the adenovirus vectored vaccines, which are also relatively new technologies. Several vaccines, including Ebola vaccines, had been made based on that technology, but had not necessarily been widely used in human populations. And certainly this is the most widespread use of those new vaccines. And then in particular, the mRNA vaccines, as Dr. Smith pointed out, have been really revolutionary in their potency and their efficacy, at least against this particular virus. Doesn't mean that they will have similar efficacy against others. Their safety profile, which has been outstanding, and then their scalability, which is, I think, something that we're only now appreciating as Pfizer continues to modify their projections for how many doses of vaccine they will be able to make. They have rapidly eclipsed the production forecasts for AstraZeneca, which had been previously thought to be the workhorse of this pandemic. And I think the reason there is because, as one of my colleagues who is in the vaccine industry has pointed out, I think rather eloquently, the mRNA vaccines are the first technology that have turned the biology of vaccine making into chemistry. And as we all know, using biological systems to produce anything is very complex, often unpredictable, very finicky, and difficult to scale. And what the mRNA technology has done is taken that and put it into a chemical system where it's really just chemical synthesis that you're carrying out. And that can be done much more predictably in a much larger scale with very linear results. And that's allowed us to ramp up production quite effectively. And that, I think, is going to be a transformational technology as we move forward, not only in our fight against emerging infections, but also potentially in our fight against things like polio. So that has been a good news story. I think the lesson there also still is that while these new technologies have been revolutionary and have allowed us to produce a vaccine against a new pathogen in record time, it still wasn't fast enough. That even though a year is, again, much faster than we've ever been able to do this from scratch for a novel virus, that a year is plenty of time in our modern, globally connected world for a pandemic to wreak incredible havoc. And so we need to figure out how to accelerate that timeline even more. The next lesson I think I would take away is one that's not one of good news, and that is, again, the highlighting of the vulnerability and the fragility of our health system. And that's true both in the developed world, but also probably even more true in low and middle income countries. It is clear that our health systems were not prepared to be able to absorb this type of event and to provide surge capability for caring for large numbers of ill, as we saw in cities and regions in the US and in Europe that were experiencing large waves, and as we continue to see in places like India and today in Uganda and Indonesia and in many countries around the world that are currently experiencing large surges of patients. And that is a vulnerability that we have to address. In many ways, this could have been much worse. in contrast to the roughly 0.5% case fatality rate overall that this virus has, we could have been faced with a virus like the 1918 influenza virus that was more around 2%. And imagine if we'd had 4 times the hospitalization and fatality rates as we experienced last spring and in the fall of 2020. And you can imagine what would have happened to just about every health system across the country in the US and Europe. And so that critical vulnerability is something that we have to address. The next lesson to take away, and one that's a mix of good and bad news, is the fact that non-pharmaceutical interventions can work as well as they have in places that were able to implement them effectively. I think well beyond what had been anticipated in modeling that was done in the mid-2000s during some of the first US government pandemic preparedness activities related to the National Strategy for Pandemic Influenza. These non-pharmaceutical interventions, so social distancing, community mitigation, case identification, contact tracing, isolation and quarantine, all of those non-pharmaceutical interventions, which are the tools that you have in the toolbox before you have vaccine or any effective therapeutics, were incredibly effective. And I think you only have to look at, well, certainly looking at countries and regions that were able to effectively implement those, countries like South Korea, Japan, certainly countries that had more aggressive lockdowns, such as New Zealand and Australia. But these countries were able to really suppress transmission to the point that they were able to go back to some normal level of functioning. And then looking at the incidence of influenza and other respiratory viruses during the last year, which have been at record lows as a result of these non-pharmaceutical interventions that were put in place, show us just how well these work. And again, some of the countries that implemented them incredibly well, and I think South Korea is one of the most, one of the best examples of where that was done. They were able to avoid full lockdowns. They were able to avoid much of the economic damage and consequence that was experienced by many countries that were more aggressive with lockdowns, including the United States, where we had many more lockdowns and more extensive lockdowns than South Korea. But because they were able to effectively employ diagnostics, isolation and quarantine, case tracing, and other non-pharmaceutical interventions, social distancing, face masks, et cetera, South Korea has had remarkably low rates of infection and particularly low rates of mortality due to COVID-19. In fact, if the United States had experienced South Korea's COVID-19 mortality in terms of its deaths per million population, instead of the roughly 610,000 deaths that we've experienced in the US to date, we would have been around 13,000. So that shows you how much more effective South Korea was in implementing their non-pharmaceutical interventions. So the lessons there are these work, they work incredibly well, and they can be tools that we can use not only in future epidemics, future pandemics, but to combat things like seasonal influenza, where you have predictable periods of time in communities where influenza transmission is high, and that these interventions could significantly reduce transmission and save many lives. As I think we all know now, influenza on a seasonal basis every year kills around an average of 35,000 Americans. And that certainly doesn't have to happen. Our mortality rate from influenza has been dramatically reduced. And in fact, most years for seasonal influenza, we lose close to 200 children every year from seasonal flu. We've had one recorded death in a child in the last year from flu. So amazingly effective. And those lessons are ones that we should take and employ in future seasonal flu. But the other converse side of that coin is that you have to implement these things effectively and sensibly. And that's certainly something we have not done in the US, and many places in Europe didn't either. The last thing I will touch on that I think is an incredibly important lesson to take away. This is the first pandemic, I think, really that has emerged after the world has been completely immersed in the information age. And I think it is demonstrated in some cases for good, but to be honest, in more cases for ill, the power of the internet and particularly the power of social media and its dramatic effect as a psychological tool of manipulation across large populations. The amount of disinformation and misinformation that is circulated and has created the political turmoil and ultimately the ineffective response that we have mounted in the US and in much of the West has been in large part due to social media and information campaigns, and much of it deliberate. And so I think it has demonstrated some of the lessons that some folks from information and big tech companies have been warning us about for the past several years. And there's certainly been a number of prominent figures who were early innovators in Facebook, for instance, who've had a change of heart and have realized the monster that they've created. And I think we all saw the power of that monster here over the last year and its ability to really influence and move people, especially when wielded by people with nefarious intent. And that, obviously is a political issue, but it's also a public health issue that is going to be a consequential one that we have to tackle if we're going to continue to win the battle, not only against these emerging threats, but in vaccine preventable illnesses where we are starting to lose more and more ground. So those are, I think, the lessons to take away and the implications they have for combating the next pandemic. And again, as I led with, I think the next pandemic is unfortunately coming a lot more quickly than we would hope. And I urgently encourage everyone to start working on these lessons now and preparing ourselves better for the next time. And Ryan, I'll turn it back over to you. And Ryan, you're on mute.
Deliberately on mute. You fell right into my trap. All right. Thank you very much, James. That was fantastic as always. So for the audience, for those of us who are listening live, we are open for Q&A. You can go to the Q&A section on your Zoom panel and type any questions, and we will address those with Dr. Smith and Dr. Lawler. But I was actually hoping to start with some questions for both of you gentlemen. And the first one is, we talked a little bit about some social changes between 1918 and today. And one of the things that I was have been struck by, which I find both, frustrating yet in an odd way encouraging, was in reading the history of 1918 and seeing pictures of anti-mask demonstrations again, and different municipalities and communities having signs up mandating mask wearing, and seeing that some controversies, although one would hope that we would outgrow them as a society, there is a certain reassurance that the cognitive errors of today are not necessarily that these are problems that have been with us before. I think it's easy for us to find a lot of the negative aspects of a lot of these, and I am personally not much of a social media enthusiast. However, in terms of some of the positive impacts of social media and the interconnectedness, what do you think some of those ones are? And do you have any thoughts on how we could potentially leverage those as a scientific and as a medical community to these challenges going forward? It's a tricky one.
Well, I think we already are. In 1918, you had to subscribe to a newspaper to get local information. And subscribing to a newspaper, while not prohibitively expensive, did separate people into social classes that were fairly distinctive. There were ethnic newspapers. In the 1960s, Dr. Saul Jarko, a cardiologist in New York, took a 6-block walk around his neighborhood and found newspapers in 17 languages in roadside newspaper dispensing machines. So getting the information out in 1917 was a lot harder than signing on to the local health system. In our area, the military health system had information. Local hospitals and hospital systems had information. WebMD, Mayo had information. So there was much broader dissemination of good information if you wanted to find it. The flip side is, of course, that which Dr. Laurer has mentioned. These kind of formats, just like the yellow press of the early 20th century, don't necessarily have a lot of quality control in them. And that is a huge social issue and probably going to remain an American issue. Over.
Yeah, I would say that a significant difference is the availability of these new technologies, and the fact that they are new leads to problems. So as you both mentioned, that this concept of vaccine skepticism and anti-vaccine movements and anti-science movements, anti-masking movements, those are not new. They've been around as long as these things have existed. Even going back to Jenner, there were anti-vaccination movements very soon after Jenner introduced vaccination. What is different is the ability of information technology, the internet and social media in particular, to amplify some of these messages. And the fact that many of these anti-vaccine, anti-science messages amplify and propagate so much more readily and easily than does the truth. I will say that at the dawn of the information age and social media, I was an inherent optimist about it. That the power of people to work together collectively, freed from the bonds of institutionalized information dissemination, I thought was going to be a good revolution. I think my pendulum has swung to the opposite side, and I will probably end up in the middle eventually. So you've caught me at a dark time. I know that when the printing press was invented, the church was horrified that people were now going to have access to reading material. How horrible! But I do think there are, we're in a growth phase, an awkward growth phase here. But it's a dangerous growth phase because I think we have just realized, again, the awesome power of this new tool and have not yet figured out how to control it. And until we do, it is going to be a challenge for us. And again, we've seen it certainly in politics, but in public health, it is going to be an immense challenge. That has been one of the major obstacles to a coordinated and reasonable response in America and in the West. And so we should recognize that and look at how we figure out solutions to overcome that.
Yeah, no, I couldn't agree with you, gentlemen, more. It has been and even I think on some of within the community of science, I think we're seeing some of the challenges of social media and this interconnectedness. One of the things that I know I've wrestled with, and some of our mutual acquaintances have wrestled with, is the ways that online release of scientific data prior to the peer review process, in many cases circumventing the peer review process, has had an impact on the use of therapeutics during the pandemic, where you can upload your unreviewed manuscript onto medRxiv or bioRxiv, one of these other preprint servers, and find yourself rapidly influencing care before anyone has really had a chance to apply a lot of scrutiny to your results. I can think of 3 large platform trials looking at anticoagulation for COVID, a core, critical area of inpatient care, and obviously one that resonates with CHEST members, since that is a big part of our work in the ICU. And those trials were released by press release with a set of slides in late December, early January. We are yet to see a manuscript, and yet we have this very preliminary information that's out there, and no one's really sure what to do with that. And although I think that's perhaps a level of less societally disruptive than spread of falsehoods through or Facebook, that can still have a corrosive effect on scientific integrity and potentially be, have deeper ramifications than just, I don't have a crazy uncle, but if I had a crazy uncle, my crazy uncle getting stuff that he heard on cable news. My uncles are all very sane, very reasonable people.
Ryan, are you saying that my quintuple therapy regimen of hydroxychloroquine, ivermectin, azithromycin, and vitamin D and C is not effective against?
Well, my scabies has never been better, so that it's effective for some things.
Right.
But
Professor Smith,
you do have a tension in that if you've got something that works and you're convinced as a clinician it thinks it works,
yeah,
then there are compelling reasons to try and tell other people it works.
Absolutely.
And
so, yes.
We run into this problem every time somebody presents a series of 3 patients at a scientific meeting, and the statistician hadn't seen the work yet. The only such trial I know of that was accurate was subacute bacterial endocarditis and penicillin. You had a 100% fatal disease, and once you gave them penicillin, it worked. And people were using penicillin in medical centers around the country by the time their train could get home, and it took another month for it to get into JAMA. So there's a huge tension in that, and it goes back to the nature of the profession. There's both the scientific expertise and there's the duty to apply it wisely. And the first time I came across this in a modern articulation was William Mayo's 1906 AMA address, where he was complimenting the profession on how much good work had been done because of germ theory and new science. Robust licensing system was in place. But at the same time, public health was not working. And he articulated that preventive medicine is not the same as public health. And the doctor needed to engage in their community to help people understand how to apply the expertise. And that was, in fact, a duty that the profession acquired in response to the licensing and the building of hospitals and all the things that were the underpinnings socially of modern medicine. And so this tension between expertise and duty, I think, has been with us for well over 100 years. It will remain with us. And public health is, at the end of the day, the politics of preventive medicine. So getting the politics out of it may be a bit of a stretch. Over.
Well, I think that's probably a topic that's worth, Ryan, really an entire session on its own. And that's one where I have actually been encouraged and really very supportive of the movement of more rapid and early publication of results and transparency, so that the scientific review process could occur in the public space. I think one of the faults has been our maybe the amateur nature of our consumerism of that information that has bypassed that scientific review process, or these studies get an initial splash and press attention, but then the press doesn't follow up on what is a robust scientific discussion that does occur that either refutes or reinforces. But obviously, I think we've all experienced the current peer review process in established journals is certainly not free of politics nor bias and error. And so this is, I think, a new way to do that. Again, maybe just one that we haven't quite learned how to do as effectively as we should. But I think that's been a huge help, much more than a detriment in terms of getting scientific data out there quickly. And those who are more seasoned readers of the medical literature and understand and can interpret clinical research can weed out the chaff pretty quickly.
Yeah.
And so I've actually welcomed this change and hope that it's one that continues to grow.
I think that's a great perspective. I really appreciate that. And certainly I would be an error to say that there isn't room for reform of any institution that includes the way by which we conduct the peer review process. Absolutely. Wonderful. So one other to shift angles a little bit, we are all people with some current or prior affiliation with the federal government, and thinking about how different levels of government have responded and what their duties are to respond to disasters, including pandemics. Thoughts about changes in how, say, local, state, and federal officials have responded to both the prior pandemic and the current pandemic, and then what might we do with that in the future as a country, as a society? How can we take a look at both the things that went well and the things that went poorly to try to build something better for the next time? Purely speculative, of course. Although I will hold James personally responsible for it.
As you should. Dr. Smith, you want to go first?
In 1918 and on through the 60s, the United States public health system was local and state. While there was a United States Public Health Service, it was mostly in the business of doing research. The new CDC after the Second World War had a major emphasis on state services. If you called them and asked them for help, they would be glad to help you, but they weren't going to ask themselves in. And states, because infectious disease was the big problem, spent a lot of resources on epidemiology, on case finding. Once somebody was diagnosed with an infectious disease, you would placard a house. They were kept out of school. In broad outbreaks, the local health officer would close down the churches and the movie theaters and occasionally the schools. But it was never statewide. It was always wherever the outbreak was bad that time. I can remember traveling in the 1950s and coming up on a county that had put up a billboard that don't stop in this county because we have polio this season. And so you couldn't get a motel there. You'd have to drive all the way through. That local targeting was what we'd always done. But the New Deal and the reshaping of the power of the federal government over the last half of the 20th century following the Second World War focused our attention more and more on federal solutions to problems. And so the local public health department was taking resources that perhaps you didn't need. There wasn't a polio epidemic after polio vaccines came out. So the epidemiologist could go away and the state would have one. And then the state gave it up and CDC would have one. And so we increasingly began to depend upon the federal government for infectious disease expertise. In 1980s, rather than fix all the public health hospitals, we closed the public health hospital system, and the United States Public Health Service shrank in size to really just the people inside research and regulatory institutes, the FDA, the NIH, the CDC. There are very few public health service officers to assign to a trouble squad to help in a public health emergency. In some ways, it's not really the commissioned corps that it was originally established to be the fire brigade to go to a problem area. This is not too bad when it's a local disaster. The Four Corners virus outbreak, the Ebola and the Zika. Well, CDC and the Public Health Service had resources to mobilize. But it's a big country. And if something happens everywhere, except for the military, we don't have much that can respond. And the military doesn't plan every day for pandemics. It plans every day for war. I mean, it's kind of the nature of militaries. So there's what I think is a gap that's a new gap that has arisen in the second half of the 20th century for good social and political reasons. It's hard to pay for things you don't need. But when you need them, it's very difficult to recreate them. And if a bridge falls down, it takes all summer to rebuild it. Infrastructure is right in the newspapers today, about the importance of spending money on things that didn't need money spent on them in the last election cycle, but it's taken 50 years for things to fall apart. Public health has an infrastructure that is as badly under-resourced, I would argue, at the state and local level as the bridges and highways. Over.
Thank you, sir. James?
I would agree with all that. I think that ultimately pandemics and all emergencies are local phenomenon. A pandemic is really just a collection of local epidemics, and response in any disaster is best when it is organized and assembled at a local level. And so the really profound lack of support for local public health and state public health over the last several decades has left us really vulnerable, and we need to tend to those institutions and take advantage of the many schools of public health across the country that have great resources and expertise and research that can serve as local centers of excellence to develop and cultivate that capability. The second thing is institutionally and organizationally, I think we need to look at disrupting the monopoly of health security and preparedness that currently resides in public health, right? That disease surveillance and awareness and all of that is really somewhat locked up in the CDC nationally, and oftentimes even not shared adequately with state and local public health. But beyond public health, that health security belongs to all of us, right? It belongs to not only local governments, it belongs to local businesses in the private sector, and ultimately to families and individuals. And that's an opportunity, I think, where maybe information technology can really be used for good, to start to make that information more readily available to folks. And finally, I think culturally in public health, certainly we need to look at how we adapt and change to make emergency response something that's more a mission that's embraced, which I'm not sure many in public health have done really, and B, to change the mindset. So I think certainly at CDC and in many other places, culturally over the last several decades, public health has valued certainty over anything else. And that's probably important when you're developing childhood vaccination campaigns, to make sure that the decisions you're making, the guidance you're putting out, is based on data that is scientifically valid and certain to a high degree. But in an emergency response, certainty is fatal, because what's important is speed. You have to make decisions rapidly and adjust. It's the old, what they teach the Air Force pilots in the OODA loop, right? The more times you go through the OODA loop of deciding, assessing, the more successful you're going to be. And it's the pilot that makes the most loops that always wins the dogfight. We are stuck in slow motion going around that OODA loop in public health. And it has over and over in Zika, in Ebola, in 2009, and now certainly in 2020, put us way behind the curve in our response. And we have to figure out how we change that culture.
Well, gentlemen, I can't think of a better message to close on than that. So I think we have reached our hour, and I think we're in a good place to wrap things up. So I wanted to thank all of the staff at CHEST for helping put this session together, but especially thank Professor Smith and Dr. Lawler for their expertise and their wisdom in this. And I know, I've had the pleasure of learning from these two gentlemen over the years, and I'm grateful to that all of the rest of our audience and the folks at CHEST have had the chance to do the same. So thank you both, gentlemen, and look forward to hearing from you again. And thank you to everyone for joining us today. Have a great rest of your week.
Thanks, Ryan. Enjoyed it.
Thanks, James. Thank you, sir. Thank you, Dr. Smith.